Welcome to StudyNeuro. In this lecture, we will examine the diagnosis of cerebrospinal fluid rhinorrhea, with particular emphasis on recognizing a leak and accurately identifying its anatomical location. This is an important clinical problem because subtle leaks can be difficult to distinguish from ordinary rhinorrhea. The goal is to move systematically from clinical suspicion to biochemical confirmation and finally precise anatomical localization. By the end of this lecture, you should understand what cerebrospinal fluid rhinorrhea is and recognize its major causes. We will also examine the clinical features that raise suspicion for a leak and review the relevant skull base anatomy. The second half focuses on laboratory confirmation, imaging techniques, and a practical diagnostic algorithm. The emphasis throughout is on selecting the appropriate investigation at each stage. Cerebrospinal fluid rhinorrhea occurs when cerebrospinal fluid passes abnormally from the intracranial subarachnoid space into the nasal cavity or paranasal sinuses. A true leak, therefore, requires a pathway through the dura and skull base into the sinonasal tract. Causes include trauma, surgery, spontaneous skull base defects, congenital abnormalities, and erosive lesions. The essential concept is simple. This is an abnormal communication between the intracranial and sinonasal compartments. Diagnosis can be challenging because clear rhinorrhea is common, while cerebrospinal fluid leakage may be intermittent or present in very small volumes. Blood and mucus can further obscure the appearance, and headache alone is nonspecific. Localization is equally important because persistent communication with the sinonasal tract can allow ascending infection and lead to serious intracranial complications. So two questions must be answered. Is the fluid cerebrospinal fluid, and where exactly is it leaking? Several skull base regions are relevant to cerebrospinal fluid rhinorrhea. The anterior skull base includes the cribriform plate, lateral lamella, fovea ethmoidalis, and orbital roof. Centrally, important structures include the planum sphenoidale, sellar region, and sphenoid sinus roof. The lateral skull base includes the temporal bone and tegmen. These structures form the barrier between the intracranial and sinonasal spaces. The lateral lamella is particularly vulnerable because of its thin bone. A cerebrospinal fluid leak generally requires both a dural defect and an osseous skull base defect, with cerebrospinal fluid pressure or pulsation helping drive fluid through the abnormal pathway. The resulting leak may be high flow or low flow and may occur continuously or intermittently. A meningocele or encephalocele may also accompany the defect. The important point is that finding a defect is not enough. It must correspond to the clinical pattern and suspected site of leakage. The typical presentation is clear, watery, low-viscosity rhinorrhea, often affecting one side. Drainage may increase when the patient bends forward or performs a Valsalva maneuver, and some patients describe a salty or metallic taste. Intermittent symptoms are common with low-flow leaks. The history can also suggest the cause, particularly after trauma or surgery, or when spontaneous leakage is suspected. But remember, clear rhinorrhea alone is not diagnostic. History raises suspicion. It does not confirm the leak. Examination may reveal clear unilateral nasal drainage, neurological abnormalities, or findings related to the underlying cause. When clinically appropriate, fundoscopy can assess for papilledema. Nasal endoscopy may show pooled clear fluid, a fluid meniscus, or occasionally a meningocele, encephalocele, or actively leaking defect. However, the fistula site is often not visible, especially with intermittent leakage. A negative examination, therefore, does not exclude cerebrospinal fluid rhinorrhea, and the traditional halo sign should not be relied upon. Several conditions can produce clear rhinorrhea and must be distinguished from cerebrospinal fluid leakage. Allergic and non-allergic rhinitis are common alternatives, while turbinate dysfunction may also contribute to clear nasal discharge. A tegmen defect can produce cerebrospinal fluid otorrhea, with fluid potentially reaching the nasopharynx through the eustachian tube. Persistent unilateral, clear, watery rhinorrhea, especially when resistant to usual rhinitis treatment, should raise suspicion for cerebrospinal fluid rhinorrhea. Beta-2 transferrin is widely regarded as the reference laboratory test for cerebrospinal fluid rhinorrhea because it is highly enriched in cerebrospinal fluid and can be detected using electrophoretic techniques. However, adequate fluid collection is important, and intermittent or very low-flow leaks may make sampling difficult. Specialized laboratory testing may also be required. The key point is that beta-2 transferrin confirms the nature of the fluid. It does not identify where the leak is located. Beta-trace protein provides another biochemical approach to confirming cerebrospinal fluid. It occurs at much higher concentrations in cerebrospinal fluid than in serum and can be measured quantitatively from a small sample, potentially allowing rapid testing. Interpretation can be affected by serum contamination, while renal dysfunction may alter levels, and availability varies between settings. Like beta-2 transferrin, beta-trace protein answers the diagnostic question of whether the fluid is cerebrospinal fluid. It does not localize the defect. Nasal glucose testing is a historical approach based on the relatively high glucose concentration normally present in cerebrospinal fluid. However, its specificity is poor. Hyperglycemia, inflammatory rhinitis, and contaminated secretions can produce false positive results, while infection or low cerebrospinal fluid glucose can produce false negatives. For these reasons, nasal glucose is no longer considered a reliable confirmatory test. Modern diagnosis relies primarily on more specific biochemical markers, such as beta-2 transferrin and beta-trace protein. High-resolution computed tomography is the principal anatomical study for defining skull-base bone defects. Thin-section imaging improves visualization of small areas of osseous discontinuity involving the cribriform plate, lateral lamella, fovea ethmoidalis, planum sphenoidalis, and sphenoid sinus roof. It can also demonstrate meningoceles, encephaloceles, and associated sinus opacification. Computed tomography has excellent bony resolution and is important for surgical planning. But remember, a visible defect is a potential leak site, not automatically the active leak. Magnetic resonance imaging complements computed tomography by providing better information about soft tissues and demonstrating meningoceles, encephaloceles, herniated brain tissue, meningeal abnormalities, and other intracranial findings. Magnetic resonance cysternography uses heavily T2-waved sequences to highlight cerebrospinal fluid and its potential pathways. It is non-invasive, does not require intrathecal iodinated contrast, and can be useful for slow or intermittent leaks. Computed tomography defines the bone. Magnetic resonance imaging adds information about the associated fluid and soft tissues. Computed tomography cysternography involves intrathecal administration of iodinated contrast followed by computed tomography to demonstrate contrast passage through a skull-base defect. It may be considered when clinical suspicion remains high despite non-diagnostic imaging, when multiple potential defects exist, or when precise localization is required. The technique is invasive, and successful localization depends on leakage during imaging. Small or intermittent leaks may therefore remain occult, and procedural risks such as headache, seizure, or meningeal irritation must be considered. Radionucleus cysternography is now rarely used because its diagnostic utility and anatomical precision are limited. It involves intrathecal administration of a radiotracer, followed by delayed assessment of nasal pledges. Active leakage during the study is generally required, and intermittent leaks may require prolonged imaging. Tracer can redistribute within nasal secretions, further reducing localization accuracy. Its historical role was mainly in intermittent or occult leaks, but modern computed tomography and magnetic resonance techniques are generally preferred. Intrathecal contrast-enhanced magnetic resonance cysternography may provide additional information when conventional imaging has failed, particularly in slow or intermittent leaks. However, it remains an invasive investigation, and safety considerations are important. Because of these limitations, it is not considered a routine first-line study. Its role is best reserved for carefully selected patients in whom conventional imaging has not adequately answered the localization question, and additional information could influence management. Intrathecal fluorescein can assist with intraoperative identification of difficult cerebrospinal fluid leaks during endoscopic exploration. It may be particularly helpful when the suspected site remains uncertain, multiple defects are present, or direct visualization is difficult. However, the technique is invasive and carries potential neurological complications, including seizures. Appropriate consent, dosing, and institutional protocols are therefore essential. Intrathecal fluorescein is best regarded as an intraoperative adjunct for difficult cases, rather than a routine diagnostic investigation. Difficult localization can result from intermittent leakage, low flow escape, multiple skull-base defects, or altered anatomy after previous surgery. Computed tomography may also show a defect without demonstrating active leakage. The solution is not simply to obtain more imaging, but to integrate the clinical pattern with high-resolution computed tomography and magnetic resonance studies, using advanced localization selectively when needed. The most obvious radiological defect may not be the clinically relevant one. Clinical radiological concordance is essential. Several diagnostic pitfalls should be avoided. Clear rhinorrhea should not automatically be assumed to represent cerebral fluid, and nasal glucose should not be used as definitive confirmation. A skull-base defect on computed tomography may be incidental, while a negative study does not necessarily exclude an intermittent or low-flow leak. Finally, cerebral fluid pressure disorders should not be overlooked. Reliable diagnosis depends on bringing together the clinical history, biochemical confirmation, anatomical imaging, and clinical radiological concordance. The practical diagnostic pathway begins with suspected cerebrospinal fluid rhinorrhea based on the clinical presentation and relevant history. First, confirm the fluid using beta-2 transferrin or beta-trace protein. Next, define the bony anatomy with high-resolution skull-base computed tomography, followed by magnetic resonance imaging or magnetic resonance cystoscopy to characterize the leak. If the clinical and imaging findings agree, surgical planning can proceed. When the leak remains occult, selected advanced localization techniques may be required. Emerging technologies aim to make cerebrospinal fluid detection faster and more accessible. Lateral flow immunoassays can target beta-2 transferrin or beta-trace protein using small fluid samples, while BioFET biosensors detect cerebrospinal fluid-associated proteins through electrical signals. Optical techniques are also being investigated, along with potential biomarkers such as Ditkoff-related protein 3 and tau protein. These approaches are promising, but clinical accuracy and validation remain important limitations. Conventional biochemical testing therefore remains central to current practice. In conclusion, cerebrospinal fluid rhinorrhea represents an abnormal connection between the intracranial cerebrospinal fluid space and the sinonasal tract. Biochemical testing confirms the fluid, while high-resolution computed tomography defines the bony anatomy, and magnetic resonance techniques add complementary information. Difficult cases may require advanced localization. Above all, the radiological defect must explain the clinical leak pattern. Prove the fluid is cerebrospinal fluid, identify the defect, then establish that the defect is responsible for the leak. Thank you for joining this StudyNeuro lecture on the diagnosis and localization of cerebrospinal fluid rhinorrhea. The aim is not simply to recognize a clear nasal discharge, but to understand how clinical assessment, biochemical confirmation, and anatomical imaging work together to identify the true leak. Continue learning with StudyNeuro for high-yield neuroscience education and clinical pearls. Like, comment, share, and subscribe, and stay tuned for the next lecture.